Conditions in the places where people live and work affect a wide range of health risks and outcomes. Population health brings significant health concerns into focus and addresses ways in which communities, healthcare providers, and public health organizations can allocate resources to overcome the problems that drive poor health conditions in the population. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hetterly, senior writer at AHA and your podcast host. The AHA is committed to driving the development of accessible and equitable health services by connecting care with community. In this podcast, we're discussing population health with Nancy Myers, Vice President of Leadership and System Innovation for the AHA Center for Health Innovation. Nancy, can you tell us about your background and your role here at the American Hospital Association?
So I've worked in healthcare for over 30 years now. I spent a good part of my career working on the payer side of healthcare and then the last several years working in health systems. But the common focus of what I've been doing over the course of my career is really figuring out how it is that we can make it easier for folks with healthcare conditions as well as folks who are healthy to get the services they need at the right place and the right time. Here at AHA, my role is to help shepherd our work to support hospitals and health systems as they're evolving to more integrated models of care, including thinking about how they can partner in their communities to provide better care together for the patients as well as community members that they serve.
We hear the term population health a lot. How would you define it?
Yeah, it's a pretty trendy term, but here's how I think about it. In healthcare, we care for one patient at a time, and that's what we should do. But at the same time, we've always known, and we're now building out the tools to understand better, that there are patterns of need and utilization and intervention that are common across groups of individuals and that really influence whether and how people stay healthy or recover once they're faced with an illness. One of those patterns involves social determinants of health. What are the factors in someone's living environment or in their personal life that factors in on how they're able to stay healthy or return to health once they're ill? And, it's no surprise to any of us that because we are all people at heart, that we don't exist alone, and that our immediate world of family, friends, and environment have that enormous impact on our health. And finally, we've also known for a long time that the assets in the community in which we live impact our health as individuals. So when I think of population health, what I think of is that it's a term that refers to our understanding of that bigger picture, so that ultimately we can design and reconfigure or re-engineer our healthcare services and work with partners in our communities to recognize and intervene more automatically to address what's common for all of us in terms of factors that affect our health and recovery. And the ultimate goal of that is that leaves our practitioners, our physicians, our nurses, our other clinicians with more time and more focus on what is really unique about the individual in front of them.
That sounds like a whole new way of doing business.
It's not really a new way of doing business, although I think sometimes it feels like it is. I see it more of just an evolution of how we're providing care. Healthcare has always been a team sport. It's just that the available bench to that team, to use a sports analogy, is changing and expanding. And the shift makes sense in terms of where we are in the 21st century. We've had a rapid boom in the last decade of tools that facilitate this evolution in our understanding of the needs of patients and of groups of patients. It's only just been in the last 10 to 15 years that we've had electronic health records become widely adopted. We're also seeing a lot of new computer applications every day that are being developed to be able to integrate and analyze health data. And we've got a lot of new ways to intervene with and for patients, families, and communities that we never had before. 10 years ago, We didn't really know what Facebook was. Today, we see that as an important and powerful means of social connection and interaction between individuals. There are a lot of tools that are evolving in healthcare that will help us care for individuals and support health in our communities in different ways. So it makes sense that our shift in healthcare is evolving to be able to take into account all of the new information and tools that are available to us.
So if we're taking care of one patient at a time, what's an example of a population intervention?
So a very common condition that we're seeing in the United States is diabetes. More and more folks, for a variety of reasons that are pretty well known, are facing the diagnosis of diabetes. So it's become an important focus for us in healthcare. So if we think of the old way of doing things, and someone who was facing a condition of diabetes, the way that they would access care is they would have to remember when it was time for them to be seen or how often they should be seen. They would have to pick up the phone, make an appointment, come in to see their physician. And during the course of that very brief office visit, in addition to talking to them and figuring out what's going on with them, the physician would be scrambling to try to figure out what are the routine tests that this patient needs to have done, what are the common things, assessments that should have been taken care of. And so the physician-patient interaction was really focused around just processing routine interventions. With the technology that we have now, we're able to do much better for that patient. Today, we view diabetes from a population lens and could put into play a whole different pattern of care. So instead of having a physician-based approach, we have a team-based approach. So we're able to scour the medical record, find out who our population of diabetic patients are, who has or has not been seen, who needs what services, and get all of those routine services and exams and interventions ordered and taken care of before the patient even walks into the room with the physician. That way, when the physician and patient have that time together, it allows them to really focus on the unique aspects of how that patient is doing with their disease process or what they uniquely need in order to be successful in living with their condition. It takes away all the noise of that common stuff because we've set up a different way of intervening and making sure that that gets done and allows us to focus on the individual at that important point of care.
How are payments for healthcare providers changing as part of this evolution?
Yeah, that's an important piece to this new way of thinking about healthcare delivery and the new models that we're putting into place. We have seen movement in the payer community, both through CMS for the Medicare and Medicaid programs, as well as for commercial insurers. And there's three main areas in which we're seeing the payment system evolving to help support a different way of providing care to patients and a different way of supporting health in communities. One way is that we've seen over the course of time, or over the last 20 years in particular, a movement toward integrating outcomes measures into payment models. So providers may still get a fee-for-service payment for the individual services that they're providing, but they have incentives to meet certain outcome measures like preventive health measures, mammography rates, or flu shot immunization rates, in order to get bonus payments. And we're seeing those bonus payments become more sophisticated and more demanding in their structure as we're achieving those outcomes. Another way that we're seeing the payment world evolving is by bundling together services so that instead of paying for one widget at a time as we provide services to patients, they're looking at an entire episode of care. So they're bundling together all of the care a patient receives around joint replacement surgery and saying, we are going to treat this entire episode as one service. And you providers work together to figure out how to better manage the patient care so that it's more integrated and works in a much more cohesive manner. And then the last thing that we're beginning to see, and I think that we'll continue to see more of in these new models, is really shifting the equation to not only say to providers, if you do well and lower the cost of care that's being delivered, you can get a share of that savings. Or at the same time, if you don't do well and you are not attentive to cost of care as you're providing care and services, you may in fact lose money or owe money back to the payer at the end of the day. So we're seeing a shift in risk and a discussion around what appropriate level of risk should be shared by the payer of healthcare and the provider of services.
Thank you, Nancy, for shedding some new light on all of these important changes across the entire healthcare ecosystem.
Thank you. I'm happy to be here and happy that the AHA can help support our providers.
For more information and resources about population health, visit www.aha.org/center. I'm Tom Hetterly, and this has been Advancing Health.